members of the public and colleagues on the Board of Directors to this, the October SWFT board meeting. I'm delighted to start this afternoon session with a celebration of two colleagues who have won the Going the Extra Mile Awards, Jackie and Jade. So I will read out their commendations. And Jackie, congratulations, I'm doing you first. So Jackie works as a help desk telephonist in the Estates Department. My mum was a telephonist, Jackie, for 30 years, so you're in good company. She was chosen for the non-clinical Going the Extra Mile Award winner after being nominated by a member of staff for being a supportive colleague who consistently goes the extra mile to help and assist everyone. The person who nominated you, Jackie, noted that you've worked for the Trust for many years, you're extremely dedicated, professional, hardworking, compassionate, friendly, kind, organised and communicates very well. Jackie, you don't want a job on the board, do you? She works across multiple trust sites as well as with contractors. The nominator also said Jackie helps to keep morale high by always making people laugh and smile. So Jackie, congratulations. You're one of our Going the Extra Mile Award winners. Thank you. My mum used to have a telephone voice. I'm not sure if you have a telephone voice, but my mum used to have a telephone voice. And then our clinical winner is Jade. Hi, Jade. Lovely to see you. Jade is a registered nursing associate with us. And you were nominated, Jade, after a patient living with terminal cancer and a short prognosis took the time to nominate you. They said that every ward should have a Jackie in their team because she's very caring, kind, supportive and hardworking, and goes above and beyond to ensure patients have as pleasant a stay as possible. The patients said during their time on Mary ward that Jade had been compassionate at all times while taking into consideration their diagnosis. She has been sensitive and yet honest with helping them figure out their wishes for their final weeks. She's also been very trustworthy and devoted to granting the nominators' wishes to have their final weeks at home. They noted they couldn't thank Jade enough for all she's done for them. What a wonderful nomination, Jade. Thank you on behalf of the Trust and everyone.
Thank you.
So really lovely nominations, ladies. Thank you very much for the daily hard work that you did. And I know there are many colleagues who do similar great things, but it is wonderful that we as a board can sort of congratulate some of you for going the extra mile. You have great rest of your days. You're very welcome to stay with us for the rest of the board, but we'll understand, particularly you, Jade, as you appear to be outside on a lovely blue sky.
I wish I was. I'm on the ward.
You've got a good background then. Well, thank you very much for your hard work and send our regards to your colleagues. Thank you.
Thank you very much.
Bye.
Bye-bye.
So, team, in terms of apologies for absence, we don't have any as we're blessed to have Charles with us today. So thank you, Charles, for being with us. And but we have got a very full agenda. So I will keep things moving, hopefully in an efficient way. So any new declarations of interest? Please raise a digital hand if you've got any new declarations of interest. I have one. My son now is employed by Deloitte, who are the auditors of SWFT. So the last set of minutes, was everyone happy with the accuracy of the minutes of the 1st of September? Please raise a digital hand if you wanted any adjustments made. And Bruce, thank you for chairing in my absence. Okay, can't see any raised hands, so we'll go then to page 15 to the action points arising. The first was on the integrated performance dashboard to calculate the income for the first quarter using payment by results tariff. You did that, Kim, thank you very much. The second was on the winter flu and phase 3 COVID vaccination plan. That was to rate A2 of the vaccination plan to be amended to amber instead of green. Fiona, thank you for doing that. Then on the Clinical Governance Committee, it was to keep the board appraised of progress with the PATH Service Network meeting. Glenn, I think we do need to become more demanding of colleagues in the system, that we rely on them to provide the service for our citizens. Where are we on this one?
So we are being promised a network meeting. One hasn't happened yet. One development that we talked about previously has moved forward on, which is the SWFT histopathology team are now picking up the George Eliot histopathology work, which is helpful for the sustainability of that service, but we still need to have a network meeting. Okay.
Maybe you and I can have a discussion as to whether I should formally write to the chair of the PATH. And then on the monthly safe staffing report, the team to ensure the non-clinical staff be reviewed on a quarterly basis to see where staffing challenges were prevalent. So that's going to be ongoing. Thank you, team. And also on that same report, to establish how many times the Bluebell unit are closed due to staff shortages. Fiona? Come in, Fiona.
Oh, sorry, I was struggling with mute. Yes, I've got those figures. We had 15 instances where Bluebell was closed in 18-month period. It was very, very low, really. It was probably just 5 of them up until June, but the others, 5 in July, 4 in August, and another 2 in September. That has raised this concern, and as you know, Chair, I've been reporting through the safe staffing report and through the dashboard my concerns about the staffing levels in maternity and the approach that we're taking in terms of increasing some of the establishment, doing an establishment review, supporting the leadership there. So I'll give some more commentary to that in the staffing paper, so to give more assurance of the actions being taken.
Great. I know the maternity nursing or nurses are rare as mustard at the moment across the system. Glenn, anything you'd like to add?
Yeah, just to be absolutely clear, just under those circumstances, what happens is those individual mums are moved to our main maternity unit on the same site. They're not turned away. They don't have to go to another unit, but on the same site, they go to our main unit. Yeah.
Fiona, your hand's up. Did you want to come back on that?
Yes, just in a similar vein, really. Yes, they are given care. They are moved up to Swan Ward. It is a reaction to staffing in Swan Ward as a way of pulling those staff up. Just to counter what you said around hen's teeth and maternity staff, we are actually attracting huge numbers of midwives to SWFT. Our recruitment is, we've recruited 17 in the last 3 months, all of which are now starting this month, and they're wanting to come to SWFT because of our model of care. So although they may be rare, they are wanting to come here. They are getting a good staff experience.
That's why they're rare elsewhere. They're all coming to us. It would be good, Fiona, if over the next 4 to 6 weeks or so, you and I followed up on the overnight visits we did about a month ago, just to follow up with the teams. We'll handle that elsewhere. Medical revalidation report, to bring that back in November. That's scheduled. Thank you, Charles. Then to invite 2 members of the BAME network who'd been allocated places on the National Res programme to attend a future board. This is scheduled for November as well. Then on the board assurance and risk quarterly report, Black Swan training to be activated, and that's in hand. Thank you, Anne. Then a front door review for urgent flow. That's to be included in a future Director of Operations commentary. And Stephen and Harkamel, welcome today. Stephen is Chief Operating Officer for George Eliot and SWFT for the next few months before he takes up a great new position in the sunny east of the country as Chief Executive. So Stephen, good to have you on board today. And Harkamel, lovely to see you again. Harkamel is the Acting Director of Operations, so welcome the two of you. Anything you wanted to add on this point on the front of door review of urgent flow?
No, I think what we'll do is, because Russell, if we do an update in kind of next month, and we'll pick that up and we'll get something done in the meantime and then feedback to board at the next month on that. Okay, great. Thank you, Stephen. And then staff and wellbeing plan to be included in the board workshop in October. We've deferred that, but we had a fantastic board workshop today for members of the public to be aware, looking at a number of the real opportunities and challenges that we have. We had some very open feedback from the McGregor ward about the ongoing challenges we have with troubled teenagers and young people who can be occasionally violent on the McGregor ward. So we had a good conversation about that. We also talked about our estate strategy and other matters as well, but a really good discussion this morning. And that means we're talking about staff wellbeing next month. Finally, to invite bank staff to take part in a staff story session at a future board. We're going to do that in December, Fiona. Okay, great, thank you. Are there any action points arising that I've missed? Okie dokie. So the first thing on our agenda, just in terms of items for approval, are the calendar of board and board committee meetings for the next 10 years. So I mean next financial year. Sarah?
Thank you, Russell. So I'm pleased to say it is just for 22-23. The proposed dates for the board and board subcommittees for the board to consider and approve. Each subcommittee has already reviewed the dates outlined in the schedule. Great, so there shouldn't be any surprises on that, but by the sounds of it, there may be. Glenn?
Yeah, just the board is aware we're discussing a paper later in confidential, which we'll bring into the public meeting next time, which potentially would change the way our public board meetings happen in the future, but certainly not for the next few months.
No, great, thank you, Glenn. And any other questions on those, given everyone's had the opportunity to look at them? Okie dokie. So everyone happy to approve? Please raise a digital hand if you're not happy to approve. Please all make sure we're on mute. I'm getting some interesting feedback. So duly approved. Thank you, Sarah. Then we've got the emergency planning, resilience and response core standards annual submission. Stephen? Come in, Stephen.
Apologies. I'm having to stay off camera for most of it because I keep going out. Sorry, Russell, could you just repeat?
That's okay. So we were basically saying, Stephen, that you don't want to take that job as a chief executive and instead you want to continue in role. No, it's the second point on the agenda, the emergency planning, resilience and response core standards annual submission.
Yeah, so I think what I've picked up with this is that I think there was only one area that we weren't fully compliant in, but we've got a plan to address that. What I'm going to do is pick it up with Fiona as well, because I understand we're going to transfer some of the responsibility for that. So we won't lose it in the handover. I'll make sure that's picked up. And what we're doing as well is making sure that across the group, we're getting a consistent approach to that as well. So particularly if I know for George Eliot's perspective, we're in a different, we're compliant in slightly different areas. So we're going to make sure that the three work together as well on that. So we should have that done fairly quickly.
Great, but we're substantially compliant, I think, on this submission. Glenn, anything you'd like to add?
Yeah, I think the only caution I'd add on this for all trusts is that regional colleagues are reviewing these submissions very, very carefully and looking at kind of a raising of the bar as a result of the obviously major incident we've had to deal with over COVID. So we may get some feedback from region that we need to review some elements of this, and if we do, we'll obviously bring that back to the board.
Okay, thank you, Glenn. But with that caveat, if you're not happy to approve this submission, could you please raise a digital hand? Okay, no hands raised, duly approved, thank you. We've then got the proposed change to non-executive director voting rights, given the departure of 2 of our NED colleagues. For members of the public who aren't aware, we are in the process of recruiting 3 new non-executive directors, and that process is now in the public domain. But my recommendation here is we invite Dr. Spraggart to take on voting rights with immediate effect, which David has kindly agreed to. If you're not happy to approve this elevation, could you please raise a digital hand? Okay, great, David. Thank you very much for accepting that responsibility. Okay, we now move on to the performance review and assurance part of our board. Glenn, please give us your report. Thank you.
Thank you, Chairman. So, as you say, actually, we had an excellent workshop this morning, which kind of brought home some of the pressures that some of our paediatric team are facing, which is something we'll certainly be bringing back to the board at some point, the response to that. My report covers a range of things. Firstly, the funding settlement, which I talked about last time verbally, but there's a bit more detail there. The £36 billion so far has not had all the strings attached to it. It's probably the best way to put that, and we will wait to see particularly the elective care strategy that I refer to here, which we're expecting to be published in November, which will set out what the national expectations are of the additional funding that we're putting in to ensure that we recover electives. What we do know from the planning letter that I also refer to in that first section is that for the remainder of this year, we are expected to eradicate 104-week waits across the NHS. That doesn't present a significant challenge to us as a trust, or indeed to the Coventry Warwickshire system, because we're in a good place, and we'll touch on that later. But it is a significant challenge to many parts of the NHS. I think the other thing that I would add, that second paragraph referring to £1 in every 3 of public expenditure being on NHS and social care is kind of identifies how important this is, and how the expectation will be that, having put additional resources into the NHS, that we will deliver on some of these really important things. And that kind of takes me neatly into winter. So one of the things we're going to have to try and do this winter is to maintain our elective activity, to make the improvements that I've just outlined, but against what will probably be the most challenging winter that we've ever seen. And we discussed this earlier, that just about everything that could challenge us over winter will have the dial turned right up to maximum this year, including obviously flu and ongoing COVID, but also workforce challenges. So there was a 10-point plan nationally that was set out, which really helps to emphasise that we need system response rather than hospital response to this. That's always been our approach. And indeed, this morning we looked at our discharge to assess work, which is one of the best models of discharge to assess in the country. But even that has to be reviewed. So one of the things I'll be talking to the team about is making sure that all the good practice that we have in place is appropriately right-sized, but is also to ensure that it's happening all of the time. We declared major incident a couple of weeks ago, and as a result of that, we identified some less convincing compliance with some of the things that we've said we will do. So that's something that Stephen and Harkamel and Anne and I will be discussing later today, actually. But I think this winter, it's very much about working smarter rather than working harder. And we've got to be very conscious of the pressure that our staff have been under over the last year. But if we do all the right things at all the right times, then we'll make sure that it's a safe winter for our patients. I then refer to Helen leaving us and Harkamel stepping up, and Stephen assisting also. And one of the things that Stephen will be helping us to do is to look at the leadership structure and make sure we've got resilience particularly over the winter, but also into the future. And really pleased to also see that Rose Gardner's returned to the team, who Rose is very familiar with our urgent care services here, so she's helping with that. And to help with that leadership review, we're engaging with consultants, and Charles and Anne and I have had a few sessions already with consultant colleagues. As usual, lots of great ideas coming out of those, and we will be seeking to implement the best ones as quickly as possible. Then there's a section on our information and performance team, very much a kind of back office team, but themselves have had a lot of work to do over COVID, and have really helped us to manage that and to manage recovery. And one of the things that stood out in our elective accelerator scheme locally was the work that they did on looking at our waiting list and looking at tackling inequalities on our waiting list, which was seen as best practice nationally. So that's all I wanted to pull out from those from that report. Happy to take any questions. You're muted, Chairman.
Apologies. Thank you, Glenn. It's obviously a tough time for the whole of the NHS, but we are relatively performing much better than a lot of other places. Any questions or perspectives to Glenn? Okay, colleagues, then we'll go into the integrated performance dashboard. Anne, do you want to do your summary for us, please?
Yeah, just very quickly, Chair, my summary just includes the key points that I identified when I reviewed colleagues' commentary, and really leave it with colleagues now to take you through the detail of their reports.
Okay, thank you, Anne. So shall we dive straight into Fiona then?
Yeah, thank you, Chair. Just the things that I wanted to put out, despite the pressure, despite August being a really difficult month for staffing and related to absences and summer holidays, I think it's to be commended that the falls rate, the incidents related to medicines and the safe discharge incidents have all continued a downward trend. So really pleased to show that. I think we have still got work to do on the VTE assessments, and Charles and I have just set that as an objective for the new AMD for governance to lead on that, because it is mainly around the prescribers assessing that VTE risk before prescribing. And I have outlined a number of actions that we're taking to continue to improve the FFT response rate and feedback through our friends and family test. So they're the things that I really wanted to pull out. Happy to take questions. Okay, so in overall, you're feeling reasonably assured, Fiona? Yes, yeah, thank you. Any questions or perspectives, Fiona? Okay, someone's scratching away in the background, not sure where that is. Maybe it's at my end. So moving on then to Stephen, the operations report, please.
Yeah, I think Harkamel's going to take us through this. Great, Harkamel.
Thank you. So I'm sure you've read the report, so I won't go through all of it, but I think the key things to pick out are around our ED performance, which remains a significant concern, given that our performance actually dropped to 74.4%. The backdrop against some of that is that we have had some periods of very busy time. So 70 patients in our ED all at the same time, for example, which hasn't coincided with when our beds have come up, so flow has been really problematic. And our attendances remain higher than they were pre-pandemic. As Glenn alluded to, though, we have got a new leadership team in post, and both Anne and I have met with them recently, and they've got quite a comprehensive action plan in place. So over the next few board meetings, I'm sure I'll be able to update on that. RTT continues to improve, so we actually achieved 85.3% in August, and performance is going in the right direction. Diagnostics dropped to 98.3%, but numbers are much higher than pre-pandemic and have only just started to stabilise, so we'll keep an eye on that. Cancer, I'm sure Helen said before, but our performance has been stable, and that's exactly what we wanted. I think you'll remember before that performance was absolutely up and down, and it was relatively hard to predict, whereas actually we're seeing incremental improvements, which I would say is encouraging. In terms of the ERF, we exceeded 95% for August, and we are currently working through what the new guidance looks like and how we're going to manage some of the impact on that, because a lot of it is around RTT pathways and going back to a relatively old way of counting. So we're just trying to understand what that will mean for us. And just some assurance on the 104-week waiters. As of today, we have 4. 3 of those are dated, and the patient that isn't dated has been sent a letter to see if they still want to proceed with treatment. But we are cited and have a plan with all of ours.
Okay, excellent summary. Thank you, Harkamel. And an awful lot going on in terms of change. How are you feeling, Harkamel? You know, we really appreciate you stepping up, if you like, to take the leadership role. But how are you feeling things are going, particularly with Rose returning as well?
Well, so I'm really excited to be here. Yesterday I was really daunted, but I've got through one day, so I figure the rest has got to be all right as well. So for me personally, obviously this is an amazing opportunity, and I feel really lucky that Rose has started again. I think it would have been much harder taking over this position without a bit of a leadership team beneath me. And you know, I think in Rose we've got someone really, really experienced who the clinicians really trust, and hopefully a bit of a team that we can sort of build back together. So it feels like quite an opportunity, I think, for me at the moment. Great.
Well, it's Rose is good news, and she's done a great job for us over at Wye Valley, so it's good to have her back. So questions and perspectives, Glenn?
Yeah, I was going to ask you about yesterday, actually, Harkamel, because it was a long day, wasn't it? You spent a shift with our A&E team at the end of the day. Were any insights from that you want to share in a public board meeting?
Yeah, no, it was quite interesting. So I had offered, obviously, to meet Martin earlier in the day, but I don't think I think from his perspective, it doesn't count unless it's very dramatic and I'm down there in the evening. But it was really interesting, actually. And I think one of the things I'm really pleased that we all agreed on, so Martin, Rose and I, is that actually we can chunk a lot of this up and then, you know, share that responsibility, so it doesn't all have to be held by one small team in ED who have one perspective. And so that's certainly kind of what I was going into it with, and I was really heartened that that's exactly what Martin and Rose want to do as well. So we're going to meet next week and kind of come up with a bit of an action plan with things that are probably achievable in the short term. So I think that'll be quite good in terms of giving people the confidence of actually some of this stuff we can achieve and then riding on the momentum of that. So yeah, it felt quite encouraging yesterday, and against the backdrop of really, really tricky times over the weekend, I was more encouraged than I think I expected to be.
Okay, thank you, Harkamel. Thanks, Glenn. And Rosemary?
Yes, Harkamel, again, following on ED, I wanted to understand better the increase in demand. Is this a national issue, or is this sort of, are we a victim of our own success almost? You know, are we seeing a bigger proportion of people coming to Warwick?
It doesn't look like that. It does look like this is a national problem. So I think it is, and we're seeing it on the elective side as well. It's patients starting to return and starting to get trust back in the system. So there certainly isn't just us problem. I think the thing that we need to focus on now is re-looking at some of the analytics. So if you'd have asked that question a couple of years ago, everybody would have been able to, I don't know, predict where the peaks in demand would have been, because the patterns were usually quite stable, whereas actually everything's quite new now. So I think that's a piece of work we need to sort of get under the skin of, and not just rely on what we used to think and our usual gut feeling, because everything is now different. So one of the things we sort of discussed yesterday is around actually really looking at that and really trying to understand where the actual peaks are, and are the systems that we have set up, for example, assessment hour opening times, are they still fit for purpose now and where we are now?
Okay, I'm conscious of the time, but both Stephen and Charles's hands went up to Rosemary's question. Stephen, anything you want to add to Harkamel's answer?
Yeah, just I think when we do that winter review, that's one of the things we've got to look at is, so nationally there's definitely an increase in more of the urgent treatment type attendances at ED, so we're seeing that. And the other thing I think we are going to need to really mitigate is the effect of other systems as well. So we'll definitely be seeing that here, and we're definitely seeing at George Eliot where other systems are in a worse position, and then conveyances from those systems start coming to your hospital as well. So it almost compounds it a little bit. So that's when I think when we do the winter review that we'll bring back to board, we'll pick those issues up as well.
No, very good. I was going to raise this point on mutual aid that we're giving other parts of the system, that I'd like to try and find a way that we are able to show what our performance we think would be like if we hadn't had to provide the mutual aid. so we get our core performance. Charles, anything you want to add on this point? Otherwise, I'll move us to...
I was going to make the same point, but just there is also some drift of patients under their own steam as well as diverts.
Yeah,
you know,
absolutely, and to observe as such, we've for a while had citizens from Worcestershire coming over to see us. And then final question to Sue, then we'll move on given the time.
Yes, thanks. Mine might be answered by diverts as well. I was just looking at the trend of the ambulance offloads. We're not used to seeing 150 over an hour, and I just wondered if work was being done to match that against potential diverts.
Yeah, definitely. So we're obviously working really closely with our partners in the ambulance service, and both, you know, when it's happening. So they were certainly with us all weekend, but looking over what measures we can put in place to try and lessen some of the pressure from both sides with that. And yeah, we're working as a system and on our own with them on that.
Okay, thank you, Sue. Thank you, Harkamel. We all want you to succeed. If there's anything any member of the board can do to help you, just reach out and we'll support you in whatever way we can. So moving on then to Gertie's report. Gertie?
Thank you, Chair. I'll be very brief. You can see quite a bit of detail in there about the numbers of recruits coming through, so it's positive to see we're maintaining pace. Obviously, we still have some big challenges to pick up, particularly in some areas and around nursing. Very positive that SWFT, along with George Elliott, are working with the system and pulling together a 5-year adult nursing recruitment plan that myself and Fiona have been supporting, and that we continue to run with recruitment campaigns within the IPC social distancing requirements. We've seen a slight increase in sickness in July, particularly within the family unit, and that will come back to the presentation that you've already mentioned, Chair, about McGregor Ward this morning in terms of the impact of that on our staff. There's quite a lot of targeted support going into all of those areas and any hotspot areas. I think it's also worth bringing to the board's attention that there's a very specific piece of wellbeing support work around winter resilience resource pack being pulled together across the trust and in fact George Elliott as well, so that we will be able to be as proactive in the support we provide for our staff as possible. It's really positive as well that SWFT has been chosen to be one of the NHSEI trailblazers for the health and wellbeing work, so we're signed up to that, and we'll be updating on that, and again we can bring that into the session next time around. I'll briefly comment on core skills training framework compliance, or stat and mand, and appraisal. These are two areas that we stepped down for the duration of the pandemic, and we're picking this back up with directorates. We did cancel F&P last week, but we sent out a requirement for the directorates to start to update us on their improvement trajectories moving forward. So we should hopefully start to see an improving position in this. Happy to take the questions.
Thank you, Gertie. Any questions or perspectives to Gertie? Bruce?
Thanks, Russell. When we've got the session next time, Gertie, I'll be looking for assurance that we're actually matching our support to our staff in the areas that we need them, and it's very effective, because I look at the top 10 sickness reasons. We've got a third is anxiety, stress and depression. We heard a very telling story this morning from McGregor Ward, and I'm keen that we link up to an outcome success. And to me, that large blue slice has been a bit persistent. So for the next time, some assurance, please.
Absolutely, I'll pick it up in more detail on the next. But what I would say is stress and MSK is every NHS organisation's two highest reasons for absence. We have got bespoke support in there, but we can run through some of that detail, and we'll also be feeding back the outcome of the health needs assessment in the next session in November.
Okay, thank you, Bruce. Colleagues, happy to move on? So, Kim, we're talking about H2 in just a second, but how's the first 5 months gone?
First 5 months, we're reporting a small surplus, £94,000, so that's a positive performance. Our cash position remains strong. I just want to draw attention to some of the productivity measures. You will see a bit of a dip, I suppose, for August. Really, that's a reflection of the fact that we've obviously had the summer holidays, so we've done slightly less activity, particularly in certain areas, and There's also an issue around some backlog coding, which is affecting the recording and depth of coding in A&E attendances, which is also skewing the charts. We expect to see, again, a further dip really for next month, and that's a reflection of the fact that we've got the pay awards being arrears being paid in September, so that might distort the charts, but I'd just like to give advance notice of that. But that's all I've got to say, I think, in terms of the position for the first 5 months of the year. Would you like me to move on to H2?
Let's just see if we've got any questions first. Lovely enthusiasm, just give me a sec. So any questions or perspectives to Kim on the first 5 months? Okay, I think clearly and we'll talk about it partly in the half two, but it's very difficult for some members of the public who are aware for us to be clear about what the income regime is, which makes the deficit position even more of a challenge. But it's why we are very focused on our reference cost position, comparing ourselves to Model Hospital, comparing ourselves to other trusts within the foundation group, so that we're driving our productivity and our cost efficiency as much as we possibly can. Just before we do the second half, though, mortality, anything you want to brief us on, Charles, on mortality?
No, the position remains well within control limits, and the shimmy, although it is very much in the rear view mirror, is very slightly lower than it's been.
Okay,
so
great.
Nothing to report.
Anything on mortality the colleagues would like to ask Charles? So it is back with you, Kim, on half two. Thank you.
Thank you. So the paper was written in advance of the guidance coming out. The guidance has subsequently been released. It came out on Thursday, but it's largely as the paper has set out. So the H2, which is the second half of the year, is broadly in line with the allocations that were given to us in H1. There's some slight nuances, particularly a slight reduction in terms of the amount of COVID support and reflection of the pay awards. They also make reference to some additional funding for non-elective winter funding, but the devil's in the detail, and I think it's fair to say we still haven't actually received the actual envelopes at the moment, so we just need to work that through. Nationally, they have notified us that there will be a further £500 million available for elective recovery, which apparently is the same as in H1. Again, trying to work out how we access that amount of money is a challenge. We're doing some modelling with the information, finance and ops teams at the moment to try and understand the rules, which are slightly different to the ones that we lived with in H1. The premise being that it is based on achieving above 89% of our completed RTT pathways, which is different from the way that the elective recovery fund worked in H1. So we're just trying to model that and understand what that means. We also need the actual baselines released nationally for us to work that one through for us. Again, though, that access to that fund is based on system performance, so it's not just about our performance. So that's a key thing. They have confirmed that H1, so first 6 months, will be taken along with the second 6 months, which is good. So it's a relief, because I was worried that we'd have to do 2 sets of accounts, but it's okay. We'll have to do one, so that's good. They talk about system a maximum sort of CIP target of 3, and actually in the plan that I took to board back in April, we had made that assumption anyway. There's also, again, the focus really is around elective recovery, cancer and urgent emergency care. And as we talked about, the elimination of 104-week waits and 52-week waits. I've also drawn attention to the system position. So for H1, as a system, there's a projected deficit for the first 6 months of the year of around £5 million. mainly driven by UHEW. The SWFT position for forecast for the first 6 months is a break-even position. Looking at the figures and the plan, we still believe that I've submitted a plan for the board to approve to a break-even for the rest of the financial year. So I'm asking the board really to note the planning assumptions and approve the H2 plan. As I said, the guidance came out and it's largely the same as what we had anticipated, really, but we're still waiting for the actual detailed allocations. There will be a bit more of an exercise to do internally with the divisions to ensure that we issue them with new control totals for the rest of the year so that we can hold the divisions to account on their financial performance. But so there's a bit more work to be done on that as well.
Thank you very much, Kim. Questions and perspectives, Glenn?
Yeah, so finding out how much money you have as you enter the second half of the year is not a great position to be in. Obviously, that's the position the whole NHS is in the way that we're managing the finances at the moment. This is hopefully the last rollover compromise arrangement, and next year we'll be back into something a bit more kind of familiar. But as Kim said, the settlement, the indications are that the numbers may be slightly better than we're seeing here, particularly the CPIP challenge could be more like 2.1 than 3%. But as Kim said, there's also some changes to COVID funding. So we need that to settle down. But against all those uncertainties, it's really important that we've got a clear set of budgets that we're allocating out to the organisation. And so that allocating to divisions and teams now, even though there's some income risks around the elective recovery fund and the overall settlement, I think is the right way forward. We can't wait any longer for that. So we'll just have to come back to the board to identify whether that brings a risk back or whether it's an improved position. And I think it will be a slightly improved position, but my glass is always half full on such matters.
Okay, thanks, Glenn. I absolutely agree. If we don't push down those budgets to the divisions, how can we expect them to manage to them? And Rosemary?
Yeah, yes, again, reiterating with the revised position, obviously still some work to be done, but hopefully we can push and with a fair wind achieve something slightly better than a break even. Although obviously the CPIP, the SIPs are going to be a challenge, and I guess that is my biggest concern, is the risk of achieving, or certainly a 3%, because there's still a long way to go to achieve, to identify and get everybody signed up for those. And obviously it needs a lot of focus on that in the next few weeks.
I think we need to get back on the front foot, to be honest, on productivity. I know there's some great work going on, but in our relentless pursuit of excellence, we need to ensure that we're getting the divisions to understand we need it to be bottom up. And Harkener, I know that's very much the philosophy you're bringing with Stephen, to push down into the divisions a responsibility to innovate and come up with the ideas to change the way we do things to make ourselves more productive. Thank you, Kim. Colleagues, happy to move on? So we're then on to the safe staffing report. I'm conscious of the fact we're losing some colleagues due to bad Wi-Fi connections. So if we do lose you, we will understand, but hopefully not, Fiona, whilst you're talking. So Fiona.
Thank you. And just wanted to pull out, because this is the normal monthly staffing paper that you see every month, and it's a fairly static position, but I just wanted to pull out two elements this time, which are slightly different. One around maternity. So you'll see that we have reported a stepped change in our birth to midwife ratio this month of 1 to 36, which is higher than we have reported for many months. And that is in relation to a slight change in methodology to bring us in line with our partner organisations, but also that increase in maternity and vacancy and sickness that that we have been reporting. I can give the public and the board assurance that we have a strong escalation process, which includes bringing in on-call managers and non-specialist midwives. Obviously the most extreme that we talked about earlier in closing the midwifery-led unit to support delivery room and SWAN postnatal ward. That is an improving position. I think this will have been our worst performance in terms of birth to midwife ratio, and it is improving this month and is forecast to continue to improve now that we are filling those vacancies. We didn't have an increase in safety concerns or safety incidents, and so I don't believe that there has been an impact in terms of safe care during this difficult time. So that was my main issue. The other is a new paragraph that that Ellie has included this time in terms of updating the board with initial commentary around our acuity review. So we do an acuity review every 6 months. The one that we do into this time really feeds into budget setting generally. We have got 5 areas that we want to go into in more detail, which has shown that their acuity has changed. They include McGregor wards, which we heard earlier on, Feldon, which has had an impact in terms of COVID and our push to move people out of Warwick site and into our community hospitals. And then some of the front door areas like Oaken and ED in relation to the impact again of COVID in the last couple of years. Some of that is already in train, and what the executive team have agreed is that we will look at those in collectively, particularly the front door, as Harkamal and Stephen looked at the front door review, what that impact is having on the acuity and the numbers of patients being admitted and what that looks like in terms of staffing requirements. So I think that piece of work now needs to be done collectively as an executive team over the next 2 or 3 months, really to feed into budget setting at the beginning of next year.
Thank you, Fiona. And great to see things like the allied health professionals preceptorship coming along, which I think will help. Questions and perspectives, Bruce?
Thank you, Fiona. Very welcome the twice yearly acuity audit of inpatient ward areas, the new paragraph, and just harking back to our evening shift, night shift visits and so on. Can you confirm that this recent reassessment includes all the wards at Leamington, and indeed we've gone round this assessment since that set of visits?
Yes, we have. Yeah. So Feldon was one of the areas that raised those concerns, and one of the recommendations that came from the acuity is that we increase that staffing. So that roster review is being done, and just looking at whether we've got the budget and we can do it, or whether it needs a new budget. And also maternity was another area, obviously, and we've taken an immediate decision to increase the staffing on nights in maternity as a stopgap until we do that longer term review.
Thank you.
And Fiona and I, like we said, will be getting out on the night shift again. If there are no other questions, I'll move us on because we're running a few minutes behind now. So the Audit Committee report for the 8th of September, including the annual report. Rosemary?
All right. Yes, thank you for that. Just wanted to highlight a couple of points on here. First of all, the external auditors presented their final external audit report for the year, which was much later than usual due to one piece of work which was only carried out over the summer, which is the value for money reporting. They gave us a positive report for that, which focused on our financial sustainability, governance, and improving economy efficiency and effectiveness. I say this was the reason why our AGM had to be delayed, because of the delay in this report. Hopefully next year, with the guidance already in place, everything should be back to normal timing. I guess in terms of our value for money, they did identify sort of 3 areas which does require continued focus on, which we obviously already talk about: our cost improvement programme, business case arrangements and the strengthening of sort of post-implementation reviews, and oversight and reporting around partnerships. And I was going to say, you've already focused on that this morning. Other things I'd just like to pull out, there was a follow-up of the pharmacy wholesale dealers license compliance, which, when they first reviewed it a year ago, had identified a number of concerns. This is something which the MHRA come into review on a fairly regular basis, and we need to have all these in place before the next inspection, which could be any time now. So real focus in terms of getting the rest of those recommendations in place. And finally, just putting out the managing conflicts of interest. Obviously, all directors and senior managers or anybody in a position of influence in the organisation is required to report any potential conflicts of interest in the organisation. So Sarah Collette does a fantastic job in recording this, but she has a real challenge in terms of trying to get and influence everybody to report. And I think there is a concern about the culture in the organisation, particularly amongst some of the medical staff, about the recognition of the importance and the requirement to report. And I think the audit committee, we were just concerned about the lack of consequences for non-compliance. I think this is something from a governance perspective we need to consider.
Okay, great. Anything you need to consider urgently, though, Rosemary, just for clarification on that last point?
I think it's particularly amongst sort of the medical staff. So looking at a way that it can be introduced or focused in terms of their annual review process, that this is identified and properly reported. Yeah, I think in some cases medics do report in a different way, and it's making sure that things are joined together in an easy way, that it doesn't create bureaucracy for them.
Thanks, Rosemary. Gertie, did you want to come in on that point?
Yeah, just very briefly, I think Rosemary's hit the nail on the head, Chair. Medics are more likely to be doing their declarations in their job planning discussions, and there will be a record of that. It's the tying up of them. So I just wanted to give some assurance to the board that we would have those declarations, because medics are required to declare their private practice, but it would be a conversation through the job planning process, which happens on an annual, or at least an annual basis. So I think it's probably just how we connect those up, but I'm happy to have a conversation with them. Caroline and apologies, I can't remember his name, who's developing the new system for our job planning.
Naresh.
That's it. Thank you.
Yes.
And I'm conscious of time, guys. And Charles, did you want to add a point?
Just very quickly, it's also, there is a probity declaration as part of the actual appraisal, as well as job planning, it's a different format. But every consultant every year has to do a probity declaration as well.
Does that include a declaration as to whether they do private practice?
Yes, and private practice has to be covered in appraisal, the scope of practice and the quality of it. So, in a way, we're collecting this information in 3 different ways, and that is part of the problem. And because appraisal is nationally dictated, we can't use the declaration of interest form in appraisal.
Okay, understood. Okay, thank you very much, Rosemary. Any other questions to Rosemary? Thank you for your diligence, Rosemary, in terms of chairing the audit committee. It's appreciated. Sorry to be putting other colleagues on time pressures in terms of summary, but we are now running late. David, the Clinical Governance Committee, the 8th of September.
Yeah, I think I'll assume that everybody's read the report. The only point that I really wanted to make was that it become obvious that there's quite a considerable backlog in colposcopy, and the committee did express some concern about the potential harm that might result from this. And as such, colleagues from the Gynae department are actually going to come back to next week's committee to discuss this further. That is a potential. There's a small, also a potential risk relating to vascular surgery waiting times. This is the assessment for vascular surgery rather than the actual surgery itself. This was raised by the podiatry department, mainly as it could result in more avoidable amputations taking place. That's not, you know, that is measured nationally as a marker of quality, so we need to keep an eye on that. And I suppose the other one that I wanted to bring up was the positive effect of having a children's chaplain in children's palliative care, but then the unfortunate risk of the funding for that particular post. And I'm still uncertain and you know, whether that is actually being addressed. But it's quite clear that the individual and the post has proved very valuable for the thankfully small number of children that are involved, but for those children and their families, it's really important.
Okay, great, thank you, David. On the first 2 points, if you can come back to us at the next meeting, just to give us updates on whether the updates have reassured you.
Will do.
On the child chaplaincy service, I thought we'd signed that off, Kim, between us. So I think the funding for that's secured for the next year, isn't it?
Yeah, we agreed the funding from the charity trustee, and and then we said we'll feed it into budget setting for next year. Yeah, so I think it's secure, David. But if they're feeling unsecured, let's make sure we close the loop and tell them they've got the money.
Yeah, that's important.
Any questions to David? Thank you, David, for chairing in Bruce's absence. And then the F&P, Simon?
Thank you, Russell. So the annual report will take as read, and the self-assessment is self-explanatory and I think perfectly satisfactory. So I think the main focus of the September F&P meeting was the pathology network, who were on parade for us and represented by Ian Sturgis and Catherine Wright. And I have to say, we were suitably concerned that we had a pre-meet before the F&P meeting to make sure we were properly aligned. But in fact, the pathology network were quite sweetness and light when they came to us. They appeared genuinely interested in resolving the problems. There was a good conversation between the two parties, and I think quite a lot of concord on what we were trying to do. So it will be interesting to see whether they actually do deliver on what they're promising. And they've agreed to come back and demonstrate it to us in January, if not before. But I do think, you know, and the proof of all of this, it will be clearly in the pudding. But for sure, there's an issue around governance on Pathology Network. And I think Glenn touched on it this morning about the series of meetings and the working governance around the Pathology Network. And I do think that's something we need to be very mindful of going forward with them. And the only other thing is we've said productivity all through the meeting, and I concur entirely. I think it is, you know, a very big issue that we can't lose track of as an organisation. But apart from that, I'm happy to take questions.
Thank you very much, Simon. Any questions to Simon? Okay, Tim, we are running about 15 minutes late, so that we're aware. So we move then to the Capital Programme Quarterly Update Report. Sophie?
Sorry, Chair, you missed me out.
So excited.
Happy.
Forgot the Foundation Group Strategy Subcommittee report, which Glenn is kindly summarising. Glenn?
Happy to take the report as read and take any questions if there are any, Chair.
Are there any questions to Glenn on that report? Okay, thank you, Glenn. Just so members of the public are aware, with Chris Lewington and Ned having resigned, Simon Page is going to be the Ned who will be attending on behalf of SWFT the Foundation Group Strategy Subcommittee meetings going forward. So thank you, Simon, for volunteering. Now we will, after much anticipation, move on to the capital programme quarterly update report. Sophie?
Thanks. Just a couple of things to draw people's attention to. So in terms of the spend on the capital programme, we've got a number of large schemes finishing in December for Christmas, as always. So we've got the car park endoscopy, surgical assessment unit, and all three of those, and medical education. So all three of those complete around November, December, which means board should see the spend then significantly increased in the last quarter of the capital programme, just to give some assurance on that trajectory on spend. The other thing to note is just we've evaluated the IT capital because of the changes in the guidelines for accounting rules, which means a number of the cloud-based schemes have now gone to revenue. So that's noted in the report. And just to finish on some good news, which is the Allsop ward is now open. Staff are really pleased, patients are really happy. So the comms team are going to do a video on that and circulate that, because normally we would have an opening, but that's obviously still quite difficult. So I'm happy to take any questions.
Thank you, Sophie. Be great to have the car park opened. Questions and perspectives, Glenn?
I was just going to comment on that, Chairman. I can actually see it now from my office. It's risen above the skyline, so it will be open very soon. And I hope we then have a time where car parking isn't a problem for the hospital.
I think we should call it the Howard and Roger car park on behalf of governors who have spent a lot of energies on it. Any other questions to Sophie? Okay, moving on then to the Council of Governors report for the 9th of September, which I will also take as read. Any questions on that update for the last Council of Governors meeting? Okay, so we move then on to risk management, the board assurance framework and risk quarterly report. Anne?
Thanks, Chair. It's an assuring report. We're on track to deliver against our plans, objectives, and meet our contractual and statutory duties. In terms of the BAF, just 2 risks have been added to those, and that's therefore information. Finally, work continues on the risk management strategy. The workshop planned for December really to focus on our risk appetite, and that information then will feed into our risk management strategy, or refreshed risk management strategy, which is on course to be presented to Board of Directors in March 22.
Thank you very much.
Thank you.
Questions or perspectives on the BAF and risk quarterly report? Only one for me is I think the risk of inflation, particularly inflation related to building materials and anything that we're constructing, are becoming very real, and I would just counsel maybe Kim and Sophie to think about whether we need to increase the profile of that as a risk on the risk report, but I will leave that with you.
Thank you.
Any other comments? So move then on to the summary of ratified policies. Anne?
Yes, it's a very short report, and take any questions on the policy that was ratified in September, the infection prevention and control policy.
Okay, great, thank you. Any questions to Anne on the ratified policies? Okie dokie, so we'll move on then to the updated register of directors and register of directors' interests. Sarah?
Thank you. So happy to take the report as read. Just wanted to add that I will need to update the register of directors' interests with your new declaration of interest, Russell, as your son being employed by Deloitte.
Thank you.
Thank you.
And in terms of the accuracy of everything else, is everyone happy with the accuracy of everything else? Okie dokie, and then so we'll move on then to the board committee minutes. The first is the audit committee of the 2nd of June. Rosemary?
Yeah. Apologies there. I've got nothing else to add, sorry.
It's okay. So any questions on the audit committee minutes of the 2nd of June, which we've talked about verbally before? Okay, thank you, Rosemary. Then the NED finance and performance of the 3rd of August, which again verbally we've talked about. Simon, anything you wanted to add?
No, nothing to add, Chair.
Okay, any questions to Simon? and then the Clinical Governance Committee of the 11th of August, which again verbally we've talked about before. Anything you wanted to add, David or Bruce?
Not from me.
Okay,
not from me either.
Okay, any questions to colleagues on that? Okay, so I think we're on to any other business, team. Any other business from board members? Please raise a digital hand. The only point I'd make is, Glenn always smiles when I come out with it, is I think that obviously with Helen leaving and the opportunities as well as the challenges that throws up, I do want us to start to really recognise as an outstanding trust, we need to be relentless in our pursuit of excellence and be more demanding of ourselves as we go forward. It is that relentlessness, that dissatisfaction. Now, I've come across other NHS organisations recently, and some of you may have also, who almost applaud themselves for achieving the smallest of things. Now, produce very glossy videos presenting all of the stuff they're doing. That's great if other organisations want to do that. I want us to be an organisation who are absolutely relentless in our desire to deliver the best health outcomes we can for the populations we serve and the best value we possibly can for the taxpayers who fund the NHS. I think that's the end of any other business. So questions from governors and members of the public. Sarah, have we had any questions from members of the public presented?
We haven't, Russell, no.
Okay, so it is always helpful for that to happen, but for members of the public who have joined us, if you have a question, do you want to raise a digital hand now? Okay, clearly stunned everyone into silence. We have our AGM on Friday morning, which we are all, I think, looking forward to. So it will be great to see members of the public digitally then as well. Hopefully next year we'll be able to have a physical meeting and a shindig and a K-lid and welcome one another again. But in the meanwhile, thank you all very much for attending. Look forward to seeing you at the next board meeting, which is obviously at the start of November. Thank you very much, everyone. We will start the confidential board at 3:15, colleagues. So we'll go off this line and I will see you at 3:15. Thank you.